All right, we're going to go ahead and get started. And then Evan, if you can let anyone into the waiting room who still may be there as I go through the introduction, that would be awesome. All right, hello everyone. Thanks for joining us on this lovely December afternoon, and welcome to the UT Sports webinar on trauma-informed care with Dr. Ragan Schriver from the UT College of Social Work. My name is Brooke Blair. I'm the Teaching and Learning Specialist in the Sports Office for the Tennessee Strong Families Grant. Initially, everybody should be on mute to try to keep the noise and feedback down, but if you have a question or would like to participate, please put that in the chat box or feel free to unmute yourself as we move throughout the session. So today we're going to be learning about trauma-informed care from one of our professors, like I said, Dr. Ragan Schriver. He is currently the director of the in-person MSW program at the University of Tennessee. And before that, he was a program consultant for Catholic Charities. And so he has a really informative and interactive session planned for us today. So we encourage you to interact and ask questions if you have them. And I'll turn it over to Dr. Schriver.
Thanks, Brooke. That was nice. So I'm psyched that everybody's here to learn a little bit about this. I feel like it's one of the most important things that we can, understand in our profession. Is understanding this whole how do we be responsive to persons who have experienced trauma in their lives. So I just want to say before I put the PowerPoint thing going here that I feel like that this is there's so much to say and we have 1 hour to say it. So I'm going to say as much as I can, and then please, if you have a question, just interrupt or say, hey, wait a minute, I don't get that, or something like that. So there's a couple of points in here, and I'm willing to share the PowerPoint with y'all if you want. I don't know if there's a way to get that to you, but if you want to, you can have this, and you can use it for trainings for other people that you're maybe working with to pass the information on with. Also, I wanted to say that that there are 3 really good books. So if you like are really get your kind of interest whetted here a little bit, 3 really good books. One, The Body Keeps the Score by Bessel van der Kolk. That's amazing. Great book. You may have read it. It's terrific. And it really kind of talks about some of the concepts I'm going to share today, but at a much deeper level. Another book is What Happened to You? And that's by Bruce Perry and Oprah Winfrey. So they wrote it together. And so it's like she asks the questions and then he provides the responses. It's a very, very great way. It gives a basic information about the brain and stuff like that in the human response to trauma. So that's, I think, a really cool, great book. And then the third one is this, which you may be thinking, oh, that looks really boring, but it's also very exciting. And it's this by Janet Shapiro and Jeffrey Applegate, Neurobiology for Clinical Social Work. And actually, the chapter 5 in here is about the neurodevelopmental impact of stress, adversity, and trauma. So that if you don't read anything else, just that one chapter is a really good one. So those are just 3 books or 3 resources I'd love to share with you. So here we go with the old PowerPoint, just what everybody wants to spend their Friday afternoon in December going to a PowerPoint. But we'll see how we do here. Before I really get super going, I just want to say that sometimes I feel like I've given this presentation a bunch and been involved in work a bunch, where sometimes when we talk about traumatic events or talk about some of these issues, that all of us are human beings, and sometimes some of it will impact us in some way, or maybe something will land on our ear in a way that we've never thought about it before, and we might have some kind of a reaction to it. Like I feel like sometimes, maybe when I'm hearing somebody speak about trauma or some sort of trauma reaction, maybe it might ring a bell with something that I've been through. So I might feel nervous or anxious or something. Please take care of yourself. Getting the CEU or whatever benefit of this is really important, but taking care of yourself is primary. So please, if you need to step away from the computer, if you need to go lie down or whatever, please do that. That's really important to recognize yourself and your own needs in taking care of yourself. So if I could ask you, if you had what's in front of you on a piece of paper, and I would ask you, could you please draw 4 straight lines? Do not pick your pencil up off the paper and connect all 9 dots. 4 lines, have to be straight. Don't pick your pencil up off the paper. Do you think you could do it? How could you do that? Take a second, see what you think. Okay, do you got it? Everybody got it? All right, ta-da, here's the answer. You have to go outside the box. You have to go outside that box. And that is what trauma responsive care is about. is that I feel like, we've oftentimes been given this sort of box that we've been given as whatever work that we're doing, whether we're, social workers or counselors or teachers or whatever. Here's the box we have to stay in, and that we can't make exceptions. And that, things even like, like I know as a teacher, well, a student is nervous, really worked up about something that's happened in their semester, and they can't get their assignment in on time. If I stay in the box, turn it in on time, that's it. But I feel like if I can say, hey, let's talk about it, let's figure this out. How can we learn from this, not missing the deadline? Then that's kind of maybe going outside the box a little bit to think about how can I be responsive to the person's needs. I just feel like that's a constant call for us when we think about this trauma responsive care. It's to not stay in the box. Business as usual kind of goes out the door a little bit. So we just want to kind of challenge a little bit of that. I just want to kind of talk about like that we have been on a journey here in understanding exactly what trauma is, how it impacts us, how we understand it. It's been a long journey since the beginning of humanity. How do we respond to these things? So I feel like that what we're trying to do for just a little bit today is with a 1 hour, conversation is to really understand that be trauma aware, with the idea that how can we move to be more trauma sensitive and trauma responsive. So I feel like that hopefully today's conversation will open a door to look a little bit more deeper. So here's a little timeline. If you go back, post-traumatic stress disorder, which I feel like is part of our nomenclature as a country or whatever, really was not defined in the Diagnostic and Statistical Manual, which lists all of the mental disorders, the third edition of that in 1980, which feels kind of recent to maybe some of us, but that feels a little bit recent to have such an important diagnostic category just defined. We can look back and see we used to call it shell shock or something like that, or somebody's jumpy or somebody as whatever. But really, now understanding what post-traumatic stress disorder is a really important concept of understanding what trauma is. But then you can kind of see that we've gone from that to understanding, all right, well, what about other important elements of understanding trauma, that it's not just PTSD, it's a trauma reaction or a trauma response that we may be having in reflection of things that have gone on for us. Now, there's a lot of terminology that we toss around. Trauma informed, like, I'm aware of it, trauma sensitive, trauma responsive, trauma specific. So I feel like if we as providers or whoever, whatever perspective that we're coming from, if we're trauma informed, then we're aware of it and we're trying to curtail or trying to think about what it is that we want to do in our practice or our teaching or our education or our work, whatever it is that we're doing, to try to be aware of persons that are struggling with trauma. But if we go up to the level 4 there, say I'm a full-on therapist, and so then I'm utilizing my therapeutic interventions to be curtailed to healing from the traumatic events that might have occurred in our life, then you can kind of see that there's gradations toward that. All we're asking for folks to do, hopefully after this little introduction, is to be informed and aware of it. So, okay, here's a quick little case study. So imagine that you are. This is the situation where there's a woman named Mary, and Mary has been going to her social worker therapist for 6 months. Okay, she's been going to her for 6 months. All right, and so she goes there weekly, and she meets with her therapist, Nicole. So Nicole meets with her each week, and she's been doing so for the past 6 months, roughly for 6 months. So what happens is that Mary one day goes to the office of the therapist. And since she's been going there for 6 months, she knows where to go. So she goes into the building, but the building, unfortunately, is kind of dark, a little bit dark. And there are not clear signs about where to go to find the therapist office, to find the counseling department in this big building. So, and actually, a couple of the lights are out, and then one of the light bulbs flashes and kind of gives this sort of strobe light effect. Okay, but since she knows where to go, she can walk through that. The first few times she went, she got lost in the building, but now she's coming. She goes into the waiting room in the counseling department. She goes into the waiting room, and there are folding chairs that are sitting there where people sit in. They're just folding chairs, and they're not put in any sort of order. They're sort of just spread out wherever anybody wants. And there's a plant, really some plants that are in the office, but the plants are kind of wilting, and there's leaves on the ground, and it's sort of droopy. So she goes up to the desk, and the receptionist says to Mary, "Hi, how can I help you?" And Mary says, "I'm here to see Nicole today." The receptionist says, Nicole had to leave immediately on an emergency. So you can either see Mark, this guy who's also a social worker, or you'll have to come back another day. So Mary begins to get a little bit nervous and says, wait a minute, I came here to see my therapist, Nicole. And so then this kind of interaction goes back and forth a little bit, but the receptionist is unresponsive to the emotional reaction that Mary is having. She remains flat and kind of like, okay, this is what, she's just not here. It's either Mark or nothing. And then Mary then begins to get kind of agitated and she doesn't know what to do with her feelings. So she begins to kind of pound on the desk and she says, came here to see Nicole. Where is she? Why are you not doing this? And then the receptionist gets kind of nervous. So she pushes a button under the desk and then out comes a uniformed security guard who escorts Mary out because she's become agitated. So when she leaves there, guess how many times Mary comes back for therapy to Nicole again? Never. So she never returns ever again. So if maybe in the chat, or maybe if you could think about what went wrong with that sort of scenario. Can you think of any things that might have gone maybe awry in that situation that might have been not clearly the way to approach things? Well, we could probably think of a few. First of all, here comes one. Let's see. Lack of empathy and flexibility on behalf of the provider. So yeah, the fact that the provider left without some sort of like something in place, like some sort of a response. Like even if there was an emergency, there's that. But like maybe if she had done something where she could have maybe provided a response. And then in capital, all staff need trauma-informed training. So the receptionist there was unable to recognize or to calibrate herself or to attune herself to the emotions that Mary was having. Now, not everybody has to, be a therapist, but like I think we could recognize sometimes we're in a behavioral health area or when people get upset, that maybe we need to just recognize that and do what we can to train the person so that they have the skills to be able to attune and to maybe de-escalate in some way. I understand what you're saying. I hear what you're saying. Let me affirm your emotion now. This is really hard. This is really difficult. Okay, great. Then Denise said many things: lack of care and concern for client, setup of the building. That's huge. So imagine, I know like myself, if I get lost in a building or get lost in my car, I just begin to get nervous. So that nervousness can begin to be a trigger for maybe a reminder of trauma in my past or something like that. And then I begin to get worked up. So then that's just not helpful. So I think you're setting the person up by not having a safe building with clearly marked, hey, here's where the counseling department is. And then imagine having to ask people in the hallway, hey, where's the counseling department? That's just telling people up and down the hallway that you had to go to counseling. And sometimes people want to keep that private, and that's important. Anyway, then I think the other idea of having a person in a uniform escort her out, that just sort of sets up some trauma response too. So as you can see in a couple of the chats there are several things that are issues about this. And so that just wasn't a very trauma-informed response. Another thing about it is that that the option was to there was no option really. Either you see Mark, who's a guy, and maybe Mary chose Nicole because she was a female and wanted to see another female provider and didn't want to see a guy, but was nervous about saying no to the guy, who knows what. But anyway, that just was not an effective thing. So let's talk through some of these issues as we go through. Bottom line of trauma-informed care is there's a paradigm shift. This is a big old step outside the box. We've gone from what's wrong with you to what happened to you. So imagine Mary in that office setting there, coming in. She walks into the waiting room. She sees a tree that's wilting and not being cared for. So that tree, well, if you can't take care of the tree, how are you going to take care of me? And the chairs are sort of uncomfortable and things like that. So then people may be sitting in the waiting room when Mary gets upset. Everybody's asking, what's wrong with her? Why can't she control herself? What's going on? But really, the question is, what happened to her in her history this is being triggered in this current moment? So that's a big deal. So I feel like sometimes when we get maybe interact with people and we find that they're frustrating or find that they're having an emotional reaction, we don't have to ask like, what the heck is wrong with you? We're going to say maybe in our mind, like, what happened to them and how can I help them in this moment? So that's the big shift. And then the second thing is a shift from control to collaboration. This is a whole thing that at all levels of care that we provide or that we interact with clients or customers or individuals to think about. I think sometimes we've been taught, well, if I'm the provider, I need to be the one with all the answers. So therefore, I need to give the advice or give the direction or set up, this is exactly what's going to happen. That can be very disempowering for people and can be a reminder of somebody's trauma in the past. Just think about it. If somebody has been traumatized, typically they have had zero control, zero input. It's been something that's done to them, something that's been laid upon them, so they don't really have a voice in what happened. So what can we do to help people kind of rebound from that or to prevent people from having sort of traumatic reactions to things is to put them into some sort of a collaborative stance. That how can they have the opportunity to be able to participate and have a voice in what's happening to them. So Mary, in this case, she's given this ultimatum: mark or no one, mark or go home. When really it could have been like, hey, we've got a couple options here. Here's a really tough situation. Can you help me figure out what's best for you? Rather than, here you have two options, this, take it or leave it. That kind of approach. Rather than, hey, here's a situation. Would you want to, just come back another day? I'm so sorry about this. Or, we've got somebody here with you. Anyway, to sort of just do it in a way where you're inviting the person into the collaborative discussion about things. That's a big, big deal. So I feel like if we ended this webinar right now, maybe those would be two really important things to talk about. So here's another thing. How do we define what trauma is? Okay, here's three different perspectives. If I could ask you guys to look at these three different perspectives and see what you think about the definition of what trauma is. All right. Some people kind of criticize these definitions, myself included, to think that trauma is an emotional response. Trauma is the American Psychological Association. That's their definition of trauma, is an emotional response to a terrible event. I mean, that's not necessarily true. It's not emotional, it's cognitive, it's physical, it's neurological, it's all encompassing. If somebody's been through multiple or even a single trauma in their life, it's all about their whole bodily systems and how that all interacts. It's not just emotional. And it doesn't have to be just some terrible event like a flood or a tornado or something. There can be trauma of attachment. There can be trauma of relationship disruption or rupture, whatever. Trauma can be someone being fired from their job. There's just different things that be considered as trauma. I don't like it when we start to list, oh, these 10 things can be considered trauma. That's not, it's everybody is an individual person. It's different. And I think there's criticisms that we could look at the other two definitions along the same lines. So here's my definition. So take it or leave it for what you think. But here's my little analogy for understanding what trauma is. So say here you live in a city somewhere. We'll say Knoxville. And Knoxville has a water removal system. So whenever it rains, the system that we have in place, the water removal system, takes the water and it goes back out to the Tennessee River or wherever it goes, and then, or some of it, whatever happens to it. So in a typical day, it rains and then the water is removed. That's just part of the story. The same thing is true for us as human beings. Sometimes rain happens in our life, stress, anxiety, tough things at work, due dates that are coming due, too many clients to deal with, whatever the situation is, that we just have this normal stress that we have in our life. Well, we have a system, a nervous system that's interacting with all the other organs and systems in our body, but we have a system to deal with that. It causes us to become either kind of that sort of elevated response where we can deal with it, or causes us to kind of like try to force ourselves to sort of calm ourselves down. Whatever, that system is in place to deal with the daily stressors of daily life. And so then it can kind of get resolved, and then we can function in our daily life. Although sometimes in a city like Knoxville, whether we have a great water removal system, maybe there might be a great big flood, or there might be too much rain in one day. That can be different forms. But then sometimes the water removal system becomes overwhelmed and becomes backed up. And then as you can kind of see in the picture, things get backed up and the water backs up on the road, then the road gets buckled and, nobody can drive on it. So then you have to adapt to different ways of getting around the town because the water removal system has become backed up because of this overload of water, or this overload of rain. That's what's going on in our body. Our body is a system that can become sometimes overwhelmed. and I'm not going to say what could overwhelm. That could be different for every single person. But if our system is becoming overwhelmed and reacting, then that impacts the other elements of our life and other elements of our physical nature. And therefore, then it impacts all aspects of our life. So say, for instance, if I'm maybe something really negative has happened to me as a young person, then that overwhelming experience that I have, just like the water being backed up impacts the road, impacts the yard, impacts the maybe buildings and things like that. The same thing's going to happen to me. It's going to impact my relationships. It's going to impact my heart, my circulatory system, and things like that. It's just going to impact all aspects of my life. So I feel like that's kind of a good way to talk to clients about it, is that maybe this little analogy of we all have a system and sometimes it gets overwhelmed. So here's a little bit of a clearer or more specific definition. It always involves an event or a series of events. It's something that is happening to you, to the person, or a set of circumstances could be another way to speak about something traumatic. An event, a series of events, or a circumstance that is experienced. The word experience is a really, really important word because it's something that we are engaging with in some way, and then it affects us in an adverse way. So that's kind of the three words: the event that we experience that impacts us in an adverse way in all kinds of different aspects of our human life. Bottom line, and this is a quote from Bessel van der Kolk: trauma is the experience rather than the exposure. So I think that that's an important thing for us to remember. And also to remember that everybody's going to react a little bit differently. Here's this little image that we have on this slide here. I think sometimes when we think about, there's 5 stages of grief, or whatever these different stages of grief happen, 1, 2, 3, that's not the case. And I think sometimes maybe we as providers, or we as, like, oh gosh, you're in the anger stage, next comes sadness or whatever, that's just, we have to be able to accept the person where they are and let them help them find the insight so they can better understand or express where they are at, the stage that they're at. So, it's interesting that I showed you that timeline earlier on about like how we've evolved in our understanding of what trauma is. So a major milestone on this journey to understanding trauma was the adverse childhood experiences research study that was done in 1998. And it was taking about 17,000 clients from Kaiser Permanente. And it was a study that was done with the CDC and Kaiser Permanente. And they did research, and they found that about 64% of the population, of the sample size of 17,000 people that were on the Kaiser Permanente health plan, had experienced at least one adverse childhood experience. And let me just kind of say real quick what that. So here's the definitions of adverse childhood experiences that Kaiser Permanente and the CDC used, clustering around abuse, neglect, and household dysfunction. Now, if you look here, this doesn't include poverty, like the fear of where's your next meal coming from, and racism, and being discriminated against and things like that. Those aren't listed here. So there's been a lot more research that's been done on those factors and how that has impacted people. But the thing about trauma is that maybe there's something that adverse that happens to you as a child or as an older adult, and then that our system becomes overwhelmed. Our nervous system becomes overwhelmed, and in that little pyramid there, we call that disrupted neurodevelopment. And because the system is overwhelmed, it has to somehow compensate for what's happening in the body. So therefore, when the body is having to compensate for this disruption, then that can lead to some impairments in our typical functioning. So maybe we're not able to clearly think, or maybe we're not having maybe our emotional expressions can be disrupted in some way. And so then therefore, if I'm having an emotional reaction, or maybe I'm not thinking things very clearly because my neurological system has been overwhelmed, then I'm going to try to do whatever I can to help myself feel better. Heck, I'll smoke, I'll drink, I'll take drugs, I'll run too much, I'll eat too much, I'll not eat enough, whatever it is, just to make myself feel better in the moment. So there's this, the body learns that it to escape some of this negative sort of feeling or a cognition or emotional response by trying to get out of that in the moment. So in the moment, I'm going to smoke, I'm going to drink, I'm whatever. I know that this is bad for me long term, but I got to feel better in the moment. And it makes sense. I mean, that sometimes when we remember, or our body is remembering some sort of traumatic experience, we're going to do whatever we can to escape that, whatever that is, even though it's maybe health risk. Well, then sadly, because we're doing that to feel better in the moment, that can make our body sick or can make our body injured in some way. Say, for instance, like I think my mode of a health risk thing is to run too much. So I ended up kind of hurting my knee a little bit. That's how I sometimes deal with stress. And so maybe if I get chronic arthritis in my knee and I keep running and run, that's a health risk behavior. Then I can't run anymore, and then I can't walk anymore, and then I can't get up. So then I can't move around. Anyway, so you see how that builds. Or someone that smokes, then that hurts their lungs, and then they can't things like that build. And then this just leads people to disease and disability and to an early death. So we talk about trauma not as just an individual problem and that we're trying to deal with one by one, but it's a public health issue. So how do we engage everybody to understand the response of trauma so that we can help people find alternative paths than some of the behaviors that you're seeing right here on the screen before you? So let's talk a little bit about this, about what exactly does this all mean. So I think what's going on is that, like I said earlier, we have a system in our body that's been created for us to be preservative for the human race. So we have this system, the nervous system, that alerts us. So just think, if I didn't have a nervous system that was there to tell me, or parts of the brain to tell me that there's danger in my environment, then our ancestors would never have survived, because they would have been out in the woods or the jungle or wherever people lived, in cavemen days or whatever, and that there might be a tiger coming. And if they didn't have a nervous system to say, hey, I smell, I hear, I see a tiger, I need to be alerted and get the heck out of here, because I know what that tiger wants, and it's not good for me. So there's this stress and the tiger thing. If we look at our evolutionary response to trauma, that we know what is alerting us to danger. So that's what's going on. Our body is doing this to be self-preservative. But the bummer is that when the tiger not only just lives out in the jungle somewhere in our ancestors' history, but lives in our neighborhood or our home or our life, and that our body is beginning to respond as if there is a tiger all the time. And so that's where we are trying to think about how do we help people kind of deal with the traumatic experiences that they've had in their life in this way. Okay, so here's this system, just real quick, a quick little run through some high school physiology class for just a quick second. We all have a nervous system with two parts, the central and peripheral. The peripheral part, of course, is our arms and legs and out in the trunk and all that kind of stuff. So, but the peripheral nervous system has two parts, which is somatic and autonomic. And the word autonomic is the one that we're going to kind of focus on for a second. Somatic is, it's telling me to move my fingers, so I move my fingers. But autonomic are the things that I'm not really consciously aware of. It's either pre-conscious or unconscious. Like, guys, my heartbeat, my temperature, my breathing regulation, things like that. That's what that all monitors. And that's what the nervous system is sort of controlling that and interacting with all the other systems of our body. But when something happens in our body, or something happens to us externally, an event, a circumstance, a series of events, then our brain begins to recognize that this is something dangerous. This is something that's not good for me as a human being. So there's a little part of the brain, a little organ in the brain, and it's behind that green part. See where the green part of the brain is, that middle part? And there's a thing called amygdala. Amygdala is a word for almond, and because it's the size of an almond, that little amygdala is. The amygdala, put in very simplistic terms, is sort of a radar. It's a memory sort of element, but that thing hangs on to memories of danger and memories of stress and memories of trauma. So when the amygdala hangs on to something, and when the amygdala attaches an event or a circumstance to something negative or harmful to me, it's going to attach to that. So say, for instance, we are in our ancestors in the cave person period, and there's a tiger out there, and we see what a tiger does and harms another person or another situation. Then the amygdala is going to hang on to that. So 2 weeks later, when we see another tiger, the amygdala is going to say, "Alarm! There's a tiger." And then the amygdala is going to say to the rest of the body systems, you need to get your heart rate going. You need to get your breathing going. You need to get your skin conductivity going, because you got to get the heck out of there, or you got to freeze and hide or something like that. So it's a fight or flight or freeze sort of response. The amygdala kicks and trips that off in the rest of the body. Just imagine that one little organ's kind of scanning the environment for sort of dangerous stuff out there so that it can kind of communicate back. to the rest of the body to say, hey, we got to do something here. So there's that amygdala that's doing that, hanging on to those things so that we remember them and keep us safe. Now, the amygdala is doing that, and sometimes in a pretty unconscious way. So say, for instance, I was significantly hurt or abused or whatever, or harmed in some way by someone who drove a purple car. Then I would hang on to that memory. My amygdala would hang on to that. But then when I see a purple car, the amygdala remembers that sensory perception, but doesn't say like, oh, that purple car, that's a purple car, has nothing to do with what happened to you in the past. It sees purple car and sends up the alarm flare, and then starts sending down messages to the yellow part of the brain. This is below the green part, and the brown part there saying heart race, skin conduct, breathing increase. So then the body begins to respond to this, and then there's an anxiety response, and there's a fear and a fight or flight response. But sadly, you're seeing a purple car drive by, and you're in class, maybe a class, or you're in a work meeting, or you're in a session with a client, and you see that purple car out there, and your body's freaking out and wants to fight, flight, freeze, but you have to sit there because, you know, we're in a modern era that we can't just run or something like that. So, but then we sit there though, and we feel this anxiety and the stress and this pain of this. So just like Mary in the waiting room in the little case study, she heard, you got to talk to a guy or you're out of here. So she heard that, and she had no control over it. She had no input in it. She saw all the things that were contributing, and then her amygdala said, you're in danger. So then therefore she was going to fight back a bit. Yes, she should have. And so, so that was the response there. The bummer about this is that, see that red part of the brain up in the front part up there? That's the prefrontal cortex. That's a pretty fancy part of the brain. Evolutionarily, it's the newest part. And as individuals developing as human beings, it's the last part to develop. Not really till you're 25 or 6 is that part fully functioning, you know. So that front part, the prefrontal cortex, it controls language, it controls rationality, it controls logic, it controls, you know, kind of it's like a governor for us, and sort of like it puts in control some of our emotional responses. But the thing about it, when the amygdala detects danger, it's communicating back down to the yellow part and the brown part. It doesn't engage that red part, because we don't have time to stop and think or develop a strategic plan about how I'm going to get the heck out of here when I see a purple car that I associate with danger, or when I see a tiger, or when I see whatever it is that my amygdala has determined is dangerous for me. So that red part of the brain is sort of cut off from the situation. So if you think about it, when I'm experiencing trauma, it's all about an emotional response. There's not a real thinking, logical response to it. So I'm going to do things that might not be real logical, or might not be real things that I would do in my normal situation when my full brain is totally integrated. Trauma can fracture our brains in a way. It disintegrates our brain. If we're in a calm state, I can sit here and verbally put into concepts and verbally say what I believe or think. But if I'm feeling super nervous and worried, I'm not going to be able to come up with good words for what I'm saying or thinking or feeling. If I'm, in a state of crisis, I'm going to act like Mary did, and I'm going to pound on the table. Mary would never have done that if her red part of her brain had been fully engaged. She could have had a conversation about what to do about this situation, but her amygdala and the rest of her body was responding in a traumatic way. So maybe there were probably errors that we make. So sometimes we wonder, like, why do our clients do these things over and over? Or why do our clients keep making this same mistake? It's because I feel like a lot of times people are just acting out of trauma, and they're not engaged with that red part of the brain. But you know what? Sadly, I think a lot of times, what do we do to try to help people that are in trauma? We sit in a chair and engage that red part of the brain and talk about it. So, I mean, I feel like that what we need to do is engage other parts of the body. Yoga, stretching, walking, whatever it is, maybe EMDR, those types of things that help interact other parts of the brain so that we're not just having to sit and talk about it. Another element of the brain that is impacted by trauma, and this can be a little bit more by like ongoing developmental or a trauma of attachment, to think about that the part of the brain that attaches the left hemisphere and the right hemisphere can be sort of worn down by trauma. And then that prevents, again, communication from one side to the other. So like, say, for instance, if the right side of the brain is experiencing some sort of emotional response, then it's hard to engage with the other part of the brain, because the communication patterns are sort of broken down. So that's what's going on in the brain. Okay, now here's a really exciting slide. because I think it has moving parts. So sometimes there's a toxic stress that can occur. It's recorded in the brain somehow. Then the body responds and releases whatever chemicals that are in the body to bring about the fight, flight, freeze response. And one of the chemicals is called cortisol. So cortisol, though, impacts our immune system, enhances the inflammatory response. It can flood other parts of the system, and it kind of can turn off some of the infection fighting part of our body response, and can also alter the genetic expression. And if our genetic expression is altered in some way in the current moment, then when we could possibly pass that on to future generations. And I think that's something really important to consider. So in the peripheral part of the brain, outside of the nervous system, outside of the brain, are all these nervous cells, these neurons that are in our body. So if we think about this, here's sort of a close-up of how they sort of interact. But here's something that the point I wanted to say. When we're babies, if you look at this first slide here, we hardly have any neuronal connections in our brain. The ones that say, "Hey, I'm hungry," "Hey, I'm tired," those are there, but the other ones are not really there. But really, by two, and here in this 6-year-old slide, we can see that there's a pretty dense number of neurons that are connected, because kids are trying different things and doing new things and trying all kinds of different stuff. But if you look at that third slide, you can see there, as an older person, that there are fewer neuronal connections because some are pruned away, but the ones that are left behind get stronger. So the point here is that as an infant, if I'm raised in a toxic, stressful environment, the neuronal connections are all going to be starting to be made. But if that dangerous sort of toxic environment continues, the only neuronal connections that are left are going to be my stress response neuronal connections. And those connections are going to get stronger and stronger because I'm using them again and again. So if I think about how if somebody comes and then maybe like Mary, maybe because of her history, she had some sort of traumatic experiences in her life, then her brain is automatically going to go to the stress response. And it's going to be hard. In therapy or in recovery, we try to build other neuronal connections to kind of decrease some of those, the stronger ones that are about, our stress response. Here's just another example of that. So another thing about memory. So let's think for just a second about memory. Memory occurs in 2 stages: encoding and consolidation. So here's something happens to us, whatever it is, or we have something we commit to memory. All right, it comes into our brain, and then it's sort of organized into different things, and it's associated with different parts of the memory. So maybe like memories about school are put together, memories about family are sort of put together, different like that. That's sort of simplistic. So here you can kind of see memories come in, and then they're consolidated. But when we get into trauma experiences, when the brain is responding and things are difficult, the memory is not recorded quite like that. I think just blips of things they're not consolidated very well. Things aren't consolidated. So really, the memory of maybe some sort of traumatic event might be associated with a color, a smell, a sight, a sound, but it might not be really contextualized. So maybe the idea of the purple car you see isn't contextualized with the person, the abuser, the situation, the time period. All that is sort of not connected to it. And really, when you think about it, sometimes we don't need all that stuff. I see an orange tiger, I need to start running. And I know that's that color, I need to start running. But the thing is that I need to think about that. So that's what goes on there. So really, when people say I'm not really connecting on what the memory is, who, what, when, where details oftentimes don't come to mind. And that's natural. It's preservative. I don't have to keep all these details. All I know is that this is dangerous and I need to somehow have a response to get out of it, if that makes sense. So that kind of helps us recognize that people that are dealing with some sort of traumatic experience or traumatic event, then they need to recognize that sometimes it's hard to recall those. So I want to kind of I want to go deep in the paint on this one, but I just want to acknowledge that attachment theory plays very much into the experiences and the discussions about trauma. So if we think about how we attach to the primary caregivers in our life from our very, very beginning of life. In that book, the What Happened to You book by Perry and Winfrey, it says that the first 6 months of life are just I mean, as important or more important than even the whole first 12 years, because those first few years, if you're an infant and the primary caregiver is looking at you and you're crying, and the primary caregiver looks at you in the eye and says, and I understand, oh, you're sad, oh, poor thing, you're sad, then that baby's brain is saying, somebody gets me, I'm validated as who I am. If I'm crying and screaming because I'm hungry, I'm a little baby, I'm crying and screaming because I'm hungry, then somebody comes and provides me with food. Again, my emotions, my experience of life is being validated. If all that stuff is ignored, or there's neglect, or there's lack of attachment in a proper way, then that leads to the trauma of attachment, and that can be kind of chronic. It can lead to chronic adaptation for the rest of the person's life. So that's a big deal. I just want to say, hopefully open the door there for further discussion about this. Basically, all the things that I've just been saying are this in a nutshell. Here we are on a typical day, just kind of going down the road. We have things the events that occur, we interpret it, we think about it, we evaluate what our options could be to respond to it, we make a plan, and then we implement it. But when there's a trauma, or there's a difficulty or a stressful event that occurs, we don't have time to process, evaluate, and plan. We stop at, I'm interpreting this as danger. Therefore, I'm going to just skip all that other stuff and go react. That typically makes sense, doesn't it? That's what we want to do. The bummer is that when we live in a world where maybe we're responding to trauma regularly, or maybe the one trauma that we've had in our life becomes the organizing principle in our life, then the danger signs keep flashing before us, and that alarm system road becomes the main highway for us. And we're never evaluating, we're never planning, we're just respond and act. And then that's when leads to a lot of different maybe mistakes that we might be making, or things that we just might make out of knee-jerk reactions to things. I want to say that the brain has organized itself to be self-preservative, but that doesn't mean that the story is over. This guy, Phineas Gage, I don't know if you've ever heard of him, but he had a tamping rod shot through his head in an accident. You can see where it went through his brain, but he was able to, I mean, not perfectly, but he was able to bounce back and be a stagecoach driver in his life later on. That's like being an old-timey Uber driver. So that kind of thing is that he was able to bounce back. I don't know if I'd want that, but anyway, he was able to do that. And just think that we can recover. There is hope for recovering from trauma. That's a really important thing to remember. And it's up to us to inform ourselves. How do we become trauma informed? And I think the idea is to remember anybody that we come in contact with, coworkers, clients, anybody that we come in contact with could have experienced some sort of trauma. So I just want to be sensitive to that and aware of that. So that's kind of that sort of universal precaution kind of an approach. Okay, I want to kind of really skip to this one thing here. So I want to say here that there's all kinds of different ways to think about how can we be sensitive or responsive to the traumatic experiences that people have had. And so Harris and Fallow came up with some ideas. SAMHSA came up, and National Council for Behavioral Health came up with some different concepts that we could think of to help us be trauma informed. And so I kind of want to run through just a couple of them to wrap up our next few minutes here together. So here they are. Here's the ones that I kind of want to focus on. This is sort of like me distilling some of the best of those three: awareness, safety, trustworthiness, choice, collaboration, empowerment, and cultural humility. So let's just talk about these really quickly, and then we'll leave a couple minutes, maybe if there's any questions that we want to ask at the end. And if you have any questions, just jump in. Okay, first of all, let's talk about safety. Well, wait. First, let's say awareness. Awareness is what you're doing today. I think everybody deserves a medal for attending this and listening to me prattle on about this, because I think it's just so important. Even if what I'm saying isn't helpful, just that maybe it puts a moment in your head to think, I need to really think about this or learn more about this. Safety is another big deal. So how do we help people feel safe? I think some of it is maybe meeting people in a safe environment. So maybe sometimes people feel unsafe by going to the doctor or going to the hospital. What can we do to sort of help people bridge that service, whatever it is that they need to bridge? Maybe we need to meet somebody in their home, or maybe we need to meet somebody elsewhere. Who knows? Whatever that is, that meeting people where they are at emotionally, but also maybe physically or in reality. That can't always be done, but just something to think about. How do I make this as much as I can about a familiar, safe place for the person? I think having a bunch of folding chairs in a waiting room is probably not the way to go. Maybe a couch or a comfortable chair or something to help the person feel safe and comfortable and sort of home-like in whatever their setup is. I think another thing is to remind the person that they're safe. Maybe we used to, when I worked at Catholic Charities, we had a sign at our home for emergency shelter for kids, and it said, "You are safe now. Welcome here. You're safe now." It was like a reminder, that they were safe. But I think saying it and putting a sign up about it is very different than actually demonstrating it. And I think another thing to think about is that, like, do all the lights work in your place? Are there clear directions as to where to go so that we don't let people get lost in the hallway or get lost on where they're going? I think clear directions in where you're going in the building, and also clear directions on like what to do in your process. Say if you've got a whole complicated assessment process. This was something that we had at Catholic Charities too. When we would provide housing for people that were coming in, maybe had been homeless, they would have to go 3 or 4 different assessments, and they had to do them in a certain order and all this. Well, that was confusing to them, and that wasn't the way to do it. It wasn't a safety generating sort of process that we had. So then we had to do like, let's just meet the person where they are. Whatever they tell us, and they won't have to repeat and tell their story 1,000 times, things like that. What can we do to sort of like make people feel safe in the best way that we can? Trustworthiness. Okay, so like if you all were to come in and talk to me, and I sit down with you and say, "Hey, trust me, everything's going to be fine." You've never met me, you don't really know, is this guy really trustworthy? Like, what's the deal? I think what might be a more of an appropriate response is, "Hey, I'd love to earn your trust. Can you tell me what that would look like? How would that be if we were trusting one another?" Then you're kind of hitting a thing like getting the person to weigh in on. That's a rare person that asks that. "Hey, I want to earn your trust. Tell me, how would that be like? What would it take to earn your trust? I probably don't have it right now because we just met, but how can I earn it in time?" I think acknowledging that, because just in reality, anytime somebody said, "Hey, trust me," sometimes that might have led to bad situations for a person. So that's just really important to remember, that word trust has been violated by people who have experienced traumatic events. How do we use it in a caring, respectful way? Choice is a big deal. So Mary, in the situation, what do you want to do? Here's several choices. Give me what you want to do. Where do you, maybe like when you're meeting somebody in your office, help them determine which of these 2 or 3 chairs do you want to sit in? Or maybe, do you want to meet here? What time do you want to meet? As much as you can to give somebody the element of choice, that's just a big deal. Where do you want to go? Whatever. I think that's an important thing. What goals do you want to work on? Rather than, "Here, you need to work on these goals, I'm telling you what to do." And that's not really the idea. And I think that when we are service providers, it's a tough kind of balance, that we want the person to rely on us and know that we know what we're doing, and that we can give good advice, and that we can give good guidance on how things need to go, but not to do it in a way that feels imposing, but where the person has a voice and a choice and a direction for themselves. This same thing, I think it's sort of a overlapping concept, is collaboration. Is how do we work together? I tell our students from the first day of their clinical social work program that we join arms and walk with our clients. If I'm saying to the client, like, "Okay, whatever," but we're there together, we're walking together, service plans developed together, shared expectations of what's going to happen with each other. I just feel like that collaborative sort of thing is essential and really important, and can be healing. Especially for somebody that's never had a voice or a choice in their own life or their own experience, or just haven't felt that way. Sometimes people feel like they don't have a choice in their own experience of life because their body doesn't give them a choice. So I think just even saying, "Hey, now I know, like, I used to work with persons that had eating disorders, anorexia. They were sort of shoved themselves into their bodies, sort of shoved themselves in a corner. I can only eat this or I'm in danger. Hey, now let's think about that. Is that true? Is that really how that is? Let's kind of collaborate here together to think about what exactly is true here, because our body can sort of lie to us because we feel like that the body's lying to us because it's what got us and preserved us up to this point. Empowerment, of course, is another sort of intertwining sort of concept. How do we help people know that they can do their own work, that they can do what they can do in their daily life. They don't need us, or we don't want to create some sort of dependent relationship with someone that we're providing the support and help to. We want to empower in the best ways that we can, that you can do this. You have strengths. This is this whole thing with maybe the idea that that maybe a child is truant in school. If you think about it, if a child has truancy issues in school, and maybe the parents bring them to a social worker or to whoever and say, hey, of the 5 days of school last week, they only went to school 2 days. They missed 3 days of the 5 last week. Maybe our question shouldn't be, what the heck went wrong those 3 days? What'd you do? Why didn't you go on those 3 days? What happened those 3 days? But to focus on what worked that got you there those 2 days. And let's build on that. What got you there on Tuesday and Wednesday, let's really zero in on that strength and build on it. That's an empowering approach rather than looking at all the things that are going wrong and all the things that are difficulty. How can we look at the trauma that you've been through, and we can talk about that for sure and acknowledge that and be honest about it. But look at the resilience that got you to where you are right now. What a strength that is. That's huge that you were able to be here today. One thing I kind of want to talk about really in that building on that strength perspective is looking at some of the things that are on the slide here: strong kinship, importance of family relationships. We know that some sort of spirituality, it doesn't have to be an organized religion, of course, or anything like that, but it maybe just some sort of spiritual practice like meditation, or maybe it can be breathing exercises and things like that can bring about recognizing that there's healing in yourself. You have strength in yourself. Community is a big deal. Beliefs about life. How do we understand our own belief about the life experience that we're living in? Those are things, resilience factors that we can kind of consider. Those kind of think about what got the kid to school on those 2 days. These are the things that we can look for and scan the person's environment for and build on. Another gigantic thing with trauma responsive care is being culturally humble. For us, as if we're providers or whoever we are, or in relationship with people that may have had experienced some sort of traumatic event, what are we doing to respect their culture? And by culture, I mean not only just are you from another country, but maybe your gender, your race, your experience of the world, your orientation, your gender experience, expression, all those things. How can I meet you where you are? And use language that you want to use. Use pronouns that you are just revealing to me. How can I do this? How can I meet you where you are and let you tell me about yourself? And how can I follow up with a respectful response to that? That's just a gigantic element of all this. Okay, so if we had time, we could talk about another case here, but just to say, let me just look at this case here, and just maybe I'll say a couple things about it. Maybe there can be some things that you all could reflect on. So Martina, a 25-year-old woman who immigrated to the United States 6 months ago by walking over the border from Mexico, comes to your agency because she's found herself pregnant. She describes to you the reasons she came to the U.S. as being violence in her own hometown, and she never felt safe. She also described the person she paid to help her get across the border who sexually assaulted her. She's been seeing a gentleman since she's come to America who's been very kind for the past 2 months. And he is the father, but she's afraid to tell him about the pregnancy because she is afraid he will leave her. She does not know what to do next. She lives in a state where abortion has been made illegal, and due to the religious belief, she doesn't want to terminate the pregnancy. So as you engage with Martina, maybe you could think about what are some of the things or some of the concepts or some of the considerations when we think about trauma, then when we think about what would we do to engage with Martina in this situation. I know that we don't have time to open up a big, long discussion about it, but I just would like to say, think about this case and maybe think about biologically, if Martina has been sexually assaulted, she's been through violence in her home country, just the trauma of leaving her country behind. There are multiple traumatic events that she's dealing with and she's carrying with her. That's all been imprinted in some way on her body, on her brain, and the way that she remembers things. So no wonder she's afraid to tell this person that she's in a relationship with about what's going on with her. And to think about what might be if there's cortisol running through her body in a stress response in this situation, what's that doing to the baby, you know, that's inside of her. And so that's a whole element to kind of consider as well. So I feel like whatever we do to try to reduce the trauma in this person, to help her realize that she has choices, she can collaborate with you on how to make a decision about how she's going to move forward with this whole situation. I think for us to come in and say, hey, listen, Martina, you got to tell this guy, hey, listen, you got to do this, you got to do that, is going to just backfire, and she's never going to come back to you. But to say, hey, look, Martina, oh my gosh, I'm just sorry that this happened to you. Let's talk about it. Will you engage with me and work with me to figure a way to make this, to kind of help you make the most out of this situation? So those are just a couple of thoughts, and that's a bunch of me talking for a long time. And I'm sorry that's not the best learning thing is for somebody to just talk at you for an hour, but hopefully there were things to think about. And if there's a question or two, maybe we could think about it. Let's hear some things that are in the chat. Oh, good stuff about the books. Lack of empathy and flexibility on behalf of the provider. That's you saw that in that case study. Oh, thanks. That's nice. Are there any questions or anything that anybody would like to say or anything like that? Yeah, the books. Yep, the books about what happened to you by Bruce Perry and Oprah Winfrey. The Body Keeps the Score by Van der Kolk, and Neurobiology for Clinical Social Work is a great book too. So, anything else? I want to be respectful of your time. Oh, good. I'm glad that a couple people liked it.
Monty says she hopes you do this again, which is great, Monty, because actually Dr. Schriver is going to be presenting for us again in February. So we will keep you guys posted on that and the topic and the specific date as it comes. So if anybody doesn't have any other questions, we'll go ahead and close up. But thank you so much, Dr. Schriver. This was really awesome. And I think you gave a lot of relatable examples and illustrations for us and gave us a lot to think about. I do want to also invite you guys to another webinar that we're having this coming Monday. I know a lot of you guys have already registered for that. It is on cultural responsiveness, which will actually piggyback perfectly off of the session that we've had today. If you do not have the link for that, if you'll email our Strong Families inbox, I'll make sure you get the registration link for that. And Evan and Chase, if one of you guys could put our help desk email and phone number in the chat box, that would be awesome. And if you guys have any other questions as things come up and you're working on your grant proposals and things before the holidays, please reach out to us. We'd love to support you in any way that we can. I know Chase and Evan take a lot of time to really thoroughly look at those things that you guys are submitting and try to get the best help that they can. So we'd love to support you in any way that we can. And we look forward to seeing most of you guys on Monday.
Also, if you will, please make sure you complete the survey that Brooke will be sending tomorrow.
Yes.
That will give us feedback and help us to plan future events like this that are beneficial to you. So
yes, thank you, Anne. I will be following up with everyone this afternoon with an email that will link that survey. So if you guys could do that for us, that would be awesome. And then I will also let you know whenever this recorded webinar is posted on the Family Advocacy Unit's website as well, because I know there was a lot of information. So I personally will probably go back and try to reference some of it. So I'm sure others would like to do that as well. All righty. Well, I hope everyone has a great Friday afternoon. Thank you for being here. December is busy and we appreciate your time. So thank you, Dr. Schriver, and thank you to all of our participants.
Thanks, everybody.
Thank you. Have a great afternoon.
Bye.